Hello students, I am Dr. Reethiika Rathan, MDS, Assistant Professor from the Department of Oral Medicine and Radiology, Vinayak Mission Sankaracharya Dental College, Salem. Today I am going to discuss on the topic CBCT. These are the contents which I am going to discuss in my further slides. CBCT is cone beam computed tomography, which is an advanced imaging technique which produces three-dimensional images of oral structures. CBCT, when it is compared to CT, it has higher resolution which provides clear images of the structures and low radiation dose when compared to CT. And the scanning time is also minimal, and the accommodation of the machine is compact and comfortable, and it is safer because of the low radiation dose. So history. CT was initially remained the diagnostic equipment for radiographing the dentistry. So later it was combined with the 3D imaging, for which it was used only in imaging of trauma, syndromes and in implants. Then in later stages in 1970s, it was combined with the C-arm, so it was only known as a predecessor of a CBCT. Then CBCT was initially used as an angiograph. Then CBCT in 1994, it was used only in the skull region, and it was the first time for examining a skull region. Then in March 2001, it was used and is commercially available as a radiographic diagnosis in oral and maxillofacial structures. The principle of CBCT. So as the name suggests, it uses a cone beam type of radiation, or it is also known as a pyramidal shaped radiation, where the cone beam or a pyramidal radiation focuses on a region of interest, and the residual attenuated radiation, that is when the radiation passes through an object and the radiation which is passed after the object is known as the attenuation radiation. This attenuation radiation focuses by a detector. This detector detects the radiation, and from this it is called as the raw data. This raw data is then transferred to the computer, where it undergoes a reconstruction stage, and this forms the 3D images of the scan data, and it is due to the volumetric elements, that is the voxel, which produces the images. The basic component of the volumetric element is the pixel, which gives the grayscales for the differentiating the contrast in the images. So during the rotation, there are multiple sequential planar images are recorded in the rotation in 180 to 360 degree rotation. So these single projection of images constitute the raw data, which is called as the basic, frame and raw images. And the series of projection data is known as the projection data, and the projection data later undergoes the reconstruction stage, where it is called as a primary reconstruction, which produces three orthogonal planes, that is the axial, coronal and sagittal planes, followed by a 3D reconstructed image. This image shows the principle of CBCT, where the object is placed in between the source and the detector. The source is opposite to the detector, where the radiation from the source, which is the cone beam or the pyramidal shaped beam of radiation, is focused on the region of interest, and the attenuated beam falls on the detector, which is then transferred to the computer for reconstruction stage, and the 3D images are formed. During the rotation, the multiplanar projection images are obtained, that is the source and the detector rotates around the patient in 180 to 360 degree to obtain the images, and this image is the raw image, after which it undergoes reconstruction in the computer to produce the 3D image. So as I said before, there are three orthogonal planes along with the 3D image. So the first image shows the 3D reconstructed view of the image, and the second image in the top right is the axial section, and in the lower left is the sagittal section, and to the lower right is the coronal section. So components of image production includes X-ray generation, X-ray detection, image reconstruction. X-ray generation includes patient stabilization, X-ray generator, scan volume and scan factor. Under patient stabilization, depending on the unit, the patient is positioned in supine or standing or sitting position. So in case of the unit is in a supine designed mission, then it needs a large footprint area for occupying the mission in the region, and it will be very difficult for the patient, if in case of a physically challenged patient, to position in that supine position. So, and in standing position, the disadvantage is that particular height, if in case of a patient is short, the height cannot be reduced to at a lower level. And in sitting position, it is the most comfortable and preferred position for exposing. But whatever it may be, the design of the unit, the most important thing is head stabilization. The head is stabilized by head stabilizers, or using bite fork or chin cup is used to stabilize the head, so that to prevent the artifacts. X-ray generator, during the scan rotation, the X-ray, the source and the detector rotates around the patient in 180 to 360 degree. So the radiation is based on the principle, and it is maintained by ALARA principle, that is as low as reasonably achievable. Scan volume, this is the important phase where we select the FOV, where FOV is nothing but the field of view. The field of view, there are three types, that is the large, medium and restricted or focused FOV. Large, and the shape of the FOV is nothing but mostly used as a cylindrical or spherical shape of scan volume. The large FOV is nothing but it is used to examine the entire craniofacial skeleton, and in medium FOV you can scan the maxilla or mandible, even both. And restricted FOV or focused FOV, which is also known as the segmental CBCT, which is used for scanning only a particular region or a quadrant or even a single tooth. So, and the last one is stitching or blending FOV, where we can stitch or blend multiple slices of focused or restricted FOV to form a large area of image. Scan factor, the series of images constituted by the projection data is detected by the frame rate to produce a trajectory arch, that is the rotation which takes place around the patient, which is from the 180 to 360 degree. Image detectors. There are two types of detectors used in CBCT. The first one is the image intensifying tube, and combined with a charge coupled device, and flat panel detectors. Image intensifying tube charge coupled device combination has a larger and bulkier and produces circular basis of images when compared to the flat panel device, which produces a rectangular shaped one. And the flat panel device is an indirect detector which has a large area solid state detector paneled with the X-ray scintillating layer. Voxel size is nothing but the volume element which is used for detailed examination of the CBCT images to differentiate between the structures of the skeletons. And grayscale is nothing but the ability of CBCT imaging which displays the differences in the imaging of the structures by contrast differences. Reconstruction. This is the place where the images are reconstructed to produce the 3D image. So this place takes place in two stages, that is pre-processing stage and reconstruction stage. This image shows a schematic diagram where the reconstruction takes place. The pre-processing stage starts in the acquisition computer, where after obtaining the raw data, it is transferred to a computer, and this is the first stage it undergoes. The image collection, followed by it undergoes pixel defect correction, exposure normalization, gain or offset adjustment. After this, it undergoes to the second stage, where it is the reconstruction stage, which occurs in a reconstruction computer. Here, there is scenogram formation. Scenogram is nothing but an element. After the conversion, it is called as the scenogram. It gives a representation number which is called as the scenogram, and this transformation is called as the conversion or transformation is called as the Radon transformation. So this corrected scenogram undergoes reconstruction by the Felt-Clamp algorithm, that is weighing the projection data followed by filtering the weight data, and there is back projection of the weight data, and then all the processing is done to produce the 3D image. The volumetric data displayed is in 4 stages, that is reorient data, correct data, explode data and format data. Reorient data. Not only in orthogonal sections, the images can be visualized. That is, the orthogonal sections, as I mentioned before, the three planes, that is the axial, coronal and sagittal sections. But even non-orthogonal sections can also be visualized. That is, curved, oblique, transverse or cross-sectional images can also be visualized in CBCT. Correct data. The images are nothing but if you can adjust the contrast and brightness so that you can visualize in a naked eye properly. Explore data. You should keep on scrolling the data so that consequently you can visualize all the sections and detect whether if there is any other lesion at any other sections. So this type of navigation is called as a sign or paging mode. Format data. This is the volumetric data where it is in the software itself so that we can select any of the formatting options. There are three types of formatting, that is multiplanar reformation, RASM and volumetric re-rendering. This image shows that multiplanar reformation, that is the linear, oblique, serial, transaxial, that is also the cross-sectional image, and curved oblique images are seen in the multiplanar reformation. Then orthogonal projection, there is volumetric re-rendering, indirect volumetric rendering, that is the RASM, indirect volume rendering, that is with the maximum intensity projection, and direct volume render. So multiplanar reformation is nothing but, as I explained before, the even non-orthogonal sections can also be visualized in CBCT. Those non-orthogonal sections are nothing but the curved, serial, transaxial, cross-sectional and oblique images. RASM. RASM is nothing but there is an increase in the slice thickness which is done by increasing the adjacent voxel to produce in the display. Volume rendering. There are two techniques, that is indirect and direct techniques. In indirect techniques, there is intensity or density of grayscale level of voxel to be displayed in the entire data. Whereas in direct, the intensity or density at a particular threshold is fixed so that above or below which the intensity or density is eliminated. Image artifacts. There are inherent artifacts, procedural related artifacts, introduced artifacts and patient motion artifacts. Inherent artifacts. There is scatter, partial volume averaging, cone beam effect. Scattered artifact is nothing but the X-ray photons which get deflected without getting absorbed by the detector. So partial volume averaging is nothing but voxel size or the scan volume is larger than the object size. And in cone beam, if the scan volume is lesser than the object size, the peripherals are cut off. That is, the upper and lower region, the region to be scanned will be cut off. Procedure related artifacts. Undersampling, scanner related artifacts, misalignment. Undersampling is nothing but when too few projections, basic projections for image reconstruction, or when the rotation is incomplete, it produces an undersampling artifact. Scanner related artifacts, if there is any misperfection in the scanner or any calibration, if there is a poor calibration, it produces a circular or ring streak like artifact. Whereas in misalignment, if the detector or the source is misaligned, it produces a double contour artifact. An introduced artifact, there is beam hardening, where lower energy photons are detected by the detectors and higher energy photons are not detected. Beam hardening is of two types, that is the cupping artifact and extinction or missing value artifact. Cupping artifact, it is nothing but the distortion due to the metallic materials or any crowns, so it produces differential absorption, so it results in a cupping artifact. Whereas in extinction or missing value artifact, if there are two dense objects and the radiation passes between those dense objects, it produces a streak of bands, dark bands for artifacts. Patient motion artifact. This, if the patient is not positioned properly or if he moves when it is positioned, and that's the reason patient stabilization is very important to rectify this artifact. It produces a double contour artifact. Strength. As I said before, The size minimum, so that it occupies a compact, it seems to be a compact machine, and cost is very less when compared to the CT. And the scanning, the speed of scanning is faster, less than 1 minute we can scan the CBCT. And the resolution, it has higher resolution when compared to CT and has a clear image, and the patient radiation dose is low when compared to CT. And the interactive analysis, even the software gives us an implant planning, and cephalometric analysis can also be done in CBCT software. The limitation is nothing but the image noise, where the number of photons are detected at each pixel reflects a true attenuation of the objects during the specific path of X-ray beam. So this produces the image noise. Poor soft tissue contrast. CBCT is mostly used for the hard tissue only. There is a poor soft tissue contrast. Advantages, as I said before, it is used for anatomical purpose, and it can be used in pathological conditions, and it has low radiation dose and the faster scanning time, and it is inexpensive and affordable. And in case of implant planning and cephalometric analysis, even CBCT software can be used. Disadvantage, the patient has to remain absolutely stationary, so he or she might feel a discomfort in standing still. And soft tissue contrast cannot be obtained in CBCT, and the computer reconstructed panoramic will not be compatible with that of the conventional OPG. And the metallic object artifact which occurs, but recent times we have an artifact reduction software, that is metal artifact reduction software, so that it minimizes the artifacts. And facility is not yet widely available, but the knowledge of CBCT is more when compared to the previous year. General application of CBCT, as I said before, initially it was used in angiography, then radiotherapy, assessment of oropharyngeal structures, otorhinolaryngology, and fracture of evaluation. Diagnosis and pre-operative assessment. This is the place our specialty takes place, where and all we can use the CBCT. As I said, evaluation of anatomical structures, assessment of impaction and extraction, paranasal sinus evaluation, forensic odontology, implant assessment, TMJ visualization, trauma, orthodontic purposes, periodontics, sinus lift procedures, and rapid prototyping, assessment of bone grafts and obstructive sleep apnea, craniofacial assessment, and endodontic evaluation, dentomaxillofacial pathology. Implant site assessment. So in CBCT there are many softwares, so it gives us the implant system also to make us comfortable for the planning the implant in the CBCT software. There are many systems available in implant software itself. So in implant itself, in CBCT we can measure the height, width for the placement of the implant, and even density can also be assessed in CBCT. And by planning what height, width you can give it to the software in the implant system software. So after that it will give us the implant planning, where you can place it in the region where you want to place the implant. Endodontics, it is used for detecting any extra canals, if there is any calcification or vertical fractures, or even non-healing previously endodontically treated patients, and in case of any endodontic instruments or overextension of the obturation, and pre-surgical treatment planning can also be done in CBCT for endodontic purpose. In orthodontics, it can be used in diagnosis, and I said cephalometric analysis can also be done in CBCT software in itself, and it can and better treatment planning also. Mandibular third molar position can also be assessed in the CBCT, where even mandibular canal can also be traced in CBCT itself, so that the position of the tooth, where it is and whether it is near the canal or not, everything can be assessed in the CBCT software. The temporomandibular joint, it can be used for analyzing the morphology of the TMJ or any pathological condition. The joint space and the function also can be assessed by the CBCT. Maxillofacial pathosis. that is the impacted canals or any supernumerary teeth or periapical lesions and benign calcification, assessment of traumas and visualization of the extent of the lesion, if there is any perforation or expansion, can be analyzed in the CBCT scan. As I said, impacted supernumerary tooth, where it is placed, whether it is buccally or lingually or near the canal or in the maxillary sinus or near the maxillary sinus, everything can be assessed in the CBCT software. In periodontitis, it can be used in morphological description of the bone, assessment of the furcation, if there are intrabony defects or buccal and lingual defects, and even in resulting in the assessment of regenerative periodontal therapy. Rapid prototyping. The models are produced from this CBCT, where it can be used in pre-surgical planning of number of complex oromaxillofacial surgeries. It helps in the deformities like trauma, tumor resection, and it provides the practitioner a higher level of confidence before performing in the oral cavity. CBCT radiological report. In future days, we might receive a report or we might give a report also. So what and all you should see or give in the report is that patient information. The name of the patient should be there. Any unique number is given for the patient, it should be mentioned in the report, and who is referring the patient, the doctor name, everything should be mentioned in the report. Even the age and which residence, everything should be mentioned in the report. And the scan information. Scan information is nothing but which mission is used for the scanning the patient was used, and the FOV used, and scan parameters should also be mentioned in the scan information. Image quality, whether the image quality is better, if there is any error, it should be mentioned in the image quality itself. And radiological findings. This is a place where we interpret the CBCT. You should measure the extent, if in case of any cyst or tumors, the extent of the lesion should be measured. If there is any perforation or expansion or break in the continuity of mandible, or it is involving the canal or maxillary sinus, everything should be mentioned in the radiological finding. Not only the specific lesion should be mentioned in the radiological finding, even other findings like if there is any periapical abscess other than the specific lesion, it should be mentioned, or any disease, dental caries, or any other findings related other than the lesion should be mentioned in the reports. And radiologic impression, that is the final diagnosis can be given. If you want to give any differential diagnosis to it, you can give to the, you can also provide the differential diagnosis in the report. And if case of any previously treated case and it is for the reassessment, you can also mention it in the difference in the impression itself. Recent advances in CBCT, that is the mega voltage CBCT. It is similar to that of the commercially available CT, but only series of projections are taken place with the mega voltage CBCT. Whereas in fine tube, it uses a unique scanning mode that we have to choose whether you need a high resolution or a wide area of image you need it. And C-arm CBCT is nothing but C-arm is combined to the CBCT, where a volumetric data of images are obtained. Thus, I conclude by saying that CBCT is an advanced imaging technique which produces 3D images of orofacial structures. So, as I said before, the advantages is like high resolution, scanning time is less, and most importantly, there is low radiation dose when compared to CT. By having a knowledge of CBCT for the practitioners, it will be helpful for them in better planning and diagnosis and treatment also. Thank you.